Hello, good morning, good evening, and good afternoon to everyone, depending on wherever you are. My name is Anafi from ASLM, and I welcome you to this session today. This is our special COVID-19 session number 43. Can you imagine? We have gone quite a number of sessions so far, and most of them have been purely COVID. And today, we thought this would be really an opportune time to really go back to some of, or what I could call one of the greatest enemies that we do have. As much as the world is engulfed with COVID-19 right now, we were talking about the World TB Day just a couple of weeks ago, and the message from everyone was the same. Let's not lose the gains that we've made in the end TB strategy, what the targets identified in the Sustainable Development Goals and other global declarations that are there. So today we want to talk about TB and COVID-19 and see how we can tackle this change. This is going to be a 1 hour long session that is going to be mostly a panel discussion. As usual, we have French language interpretation available. On my screen is actually at the bottom right. You choose English for English and choose French for French. Today, we have a special lineup of experienced speakers. Before they come through, I would like to introduce to you our moderator for the session today. And she needs no introduction on this platform. Her name is Renuka Gade, who's a senior advisor at the Clinton Health Access Initiative. Renuka, over to you.
So, thank you, Anafi, and good morning, good afternoon, good evening, wherever you're calling in from. Welcome to the ASLM session. As you know, the African Society for Lab Medicine has been hosting a series of discussions, has been really in the forefront of mobilizing action to the response for COVID. And we're very happy that today we're talking about the syndemic, COVID and TB. And we have gathered a very distinguished panel of experts. It would have been a really fun kind of interaction to be having on stage Lucica, if it wasn't for this very intense topic where we have to be very serious, because I've seen Lucica drive things with a sense of boldness and doesn't stop back on any conversation and topic. And for those of you who don't know her, which I doubt, Lucica is the executive director for Stop TB. She always signs off her emails with, "The day you give up is the day you die." And, you know, she is a passionate advocate for TB, started off as a doctor in Romania, and it's a privilege to have you, Lucica, on this panel, joined by Professor Moses Joloba, who's again the continent's expert, I would say a global expert on TB. I don't know if we can keep count of the number of articles that Moses has authored on the topic of TB. And he is currently the Dean for the School of Biomedical Sciences at the Makerere University and an authority in his own right. So what a privilege to have Moses here. And last but not the least, we have Dr. Tamryn Green, if I may call you doctor now. When I first saw you and met you via Lucica in Amsterdam, you were still a medical student. And at that point, we were really celebrating you as Miss South Africa. And, you know, it's really, I'm tempted to say that this should be a bold and beautiful conversation. But it's a great privilege that you're with us, Tamryn. Not only do you bring to us your messages on TB from the platform that you held as Miss South Africa, but now you're on the front lines witnessing COVID as well as TB. And maybe a less known fact maybe, but you're also a TB survivor and therefore a patient advocate. So bringing in all of these components would make this a very interesting session today. I want to apologize in advance in case my internet is unstable. I'm currently in India. I was traveling to visit family. And as you can imagine, the situation here, it's headlines world over, right? 300,000 COVID infections every day for the past 1 week. Today it's 360,000, over 200,000 deaths. And media coverage is that this is grossly underreported and underdiagnosed. What does that remind us of? Potentially TB, right? Underreported, underdiagnosed, whether that's stigma or whatever. And so the conversation today will then be a little bit of a sad topic, but we need to kind of charge ourselves up and say, how will we win this dual distress? And as the public health world would call it, a syndemic. A syndemic is a synergistic epidemic that involves the cluster of 2 or more disease states within a population where social and health problems are affecting the overall health and well-being of people. And that's exactly what COVID-19 and TB present in front of us. There have been several experts who've written about this endemic, lessons learned from COVID to TB, TB to COVID, how failure in one will undermine progress in the other, and how you can't COVIDize conversation, nor can you make it all about TB. So how do you come together to collectively win? We've seen that the Global Fund, which focuses on HIV, TB, and malaria, has embraced looking at COVID as a core strategy to address this time in this time of crisis. So how can we bring in the TB, the lab, and the COVID expertise around one table? So that's the conversation today. I'd encourage our panelists to challenge each other, to comment on each other's discussions. There's no presentations today. It's all pure discussion. So I'm going to start off first with you, Lucica. I've been reading about information that says COVID's really taken TB back by 12 years. And this is why USAID is issuing a call to say, how do you look at a two-way testing strategy for COVID and TB? What is you have a greater pulse and sense of what's happening around the world. Do you think it's 12 years? What's your data saying? How do you see this from where you are, Lucica?
Yeah, so thank you so much, Renuka, for the question. Allow me to first thank you very much to Anafi from ASLM. I'm very honored to share this panel with you, Professor Moses, and with Tamryn, and obviously Renuka. Great to see you. We were in many occasions together. I would say we are, I don't know if I can say partners, we are more friends, which is always great to have such a good relationship outside. And I think I can say the same for Tamryn, and I hope Professor Moses, we go at a next level of collaboration as with this, because indeed you are a treasure, not only for Africa, but for the world in terms of laboratory and TB. We are all here, and I'm very grateful to have 130 people in the audience and for them taking the time. So I hope that at the end they will say, okay, it was good, it was paid the effort to be online with these people. Because what unites at least the 4 or 5 of us here that are in the panel and in the meeting is the fact that we devote a lot of our careers, a lot of life, a lot of our time on tuberculosis. And as you know, TB was never in the spotlight. It was for a long time a disease that you know, people don't necessarily know that still exists, know that kills 4,000 people a day, know that the people don't know that it kills, like out of 4,000, 700 are children. It's a curable disease, but it's airborne. You know, the more you leave a person not diagnosed, the more will infect others. So we had a UN high-level meeting in 2018, and there was a lot of hope that the things will be pushed, and they were pushed indeed. And I think 2018, 2019 was actually some good work. And it gave us hope that, okay, it's possible. It's possible to find people with TB and put them on diagnosis and treatment. We were not in the right space, but we were in a better space in 2019. But then in 2020, the COVID situation started. And at that time, we did a modeling. So we did some assumptions last year. In kind of this time, we did a study. And we were saying at that time that we will lose around 5 to 6 years of work. That was the estimates at that time. And then in the beginning of this year, in January, February, actually, from the Stop TB side, but with a lot of support from USAID and their country teams, as well as other partners, we were able to get data from some of the high burden countries to estimate exactly what happened in 2020. Because you see, one of the big challenges, in addition to many in TB, is also the lack of real-time data. So we work at global level and even at national level with data that are 1 year old. And this is a practice that is completely wrong. It's not just for TB, it's for everyone, but now we speak about TB. You see, a lot of COVID was created because we see all this data. There are national televisions on a part of the screen, you have the figures of COVID last year in most of the countries. You don't see the same for TB because, sorry to say, but if we would have seen the impact, 4,000 people dying every day of TB, out of which 700 are children. If you do that and you show to a country, people will be like, what? But we don't have this luxury. So but we used what we had. The only country that has live data is India. So we got the live data from India. Then we got the data from Indonesia, Philippines, and few other countries that were able to provide quarterly and, till the end of 2020. And it actually shows very depressing that indeed is pushing us 12 years, that we will lose after that WHO came with an enhanced group of countries. So now we know that globally we speak probably of around 1.5, 1.6 million people with TB diagnosed less in 2020 than 2019. And we also speak of probably additional 500,000 people that will die of TB in 2020 versus 2019. Now, these figures will push us, if you look at when was the last year, we had these numbers. I just remembered we have translation, that's why I slowed a bit. It will push us to the year 2010, which means that for a lot of us, the last 11 years of work, okay, we saved lives and we enhanced treatments, but actually we are at the same epidemiological data as we were in 2010. So it's extremely frustrating. And you see, big part of it was because of COVID. Big part of it was also was due to the measures taken to mitigate COVID. So it's a kind of our problem, the fact that, like I call it chicken without heads, we didn't think in a comprehensive manner that there is something else beyond COVID. It's not enough to run all of us in one direction, like those chicken, there is a story, you have a group of chicken that are, attacked by a wolf. And running away from the wolf, they fall into a big hole and they all die. Not because of the wolf, but because of them running And I felt that sadly last year, and I think it continues even now, in most of the places, there is not only restriction to travel, but actually there are a lot of the hospitals and the clinics that deal with tuberculosis were diverted to COVID. A lot of the staff that was doing TB, because they are pulmonologists and they deal with the lungs and respiratory disease, are diverted to COVID. Diagnosis for TB that is done on the GeneXpert platform was diverted to COVID. And a lot of this makes the access to diagnosis for people very, very difficult. So to answer your question, we are in a very bad spot. We are also in a very bad spot, unfortunately, that these things, as you see, continues. This second wave in India, we are very fearful of what happens in some neighboring countries such as Bangladesh and Pakistan next. I know very well that actually African region was managed better in having less of drops in the cases notified for TB than the Asia, for example, or even Europe. Average globally is a drop of 25% in the cases diagnosed in 2020 to 2019 for TB, and around 30 to 35% for MDR-TB globally. Okay, so you have some more, some less, and so on. But as you can see, this is a huge impact pushing us back, but there is hope. But I speak on the hope. What can we do to address this issue? Because I don't want this. Yeah, I'll tell this in the next question because I can stop here.
Yeah, no, I think you've raised some really good points. You know, when you look at it in the context of numbers that you described, it's to me, the reaction is COVID is so overt in your face that you kind of having this reaction, and TB has been the silent killer for years. And it's really shocking that it continues. And now you're saying it has actually digressed and you're going back to what you were 12 years ago. And so the task ahead is even more daunting. And that's from the global perspective that you are seeing. And I want to kind of switch to Moses to say, tell us, Moses, what's happening in Uganda from your point of view? How are you seeing the interplay of TB and COVID in your country and context? And what are some of the strategies that you may have been adopting in your labs to address both?
Thank you very much, Renuka. And I think my job has been made easier by my colleague, Lucica, whom again we worked on the same problem for quite a long time. So I think it is clear that COVID adversely affected the healthcare system and involving TB. And as noted, TB had already been a problem because of difficulty in diagnosis and under-resourced. So it was heavily affected. So and the things were very worse. In Uganda, we experienced a big wave in the beginning. And of course, the reaction was tough with the lockdowns and restriction of movement, as already said. All the focus went to COVID. And more so, we got scared because of what we are hearing. And actually, the COVID was not tackled very well. It was heavily stigmatized because people were forced to be taken to hospital in ambulance, and in hospitals were isolated, which were not like our social norms. And so people, and you know, these two diseases are respiratory, as you say. And so if you had symptoms of TB, you could be a COVID suspect. And then, of course, you wouldn't want to quickly volunteer that because you could easily end up into an isolation and being forcefully taken to hospital. So the initial approach to COVID really stigmatized COVID and stigmatized TB. And as my colleague has said, there were no COVID experts. In fact, quickly, the Minister of Health knocked at my door to enter into the COVID field with my laboratories because they had the highest safety levels, and my personnel because they were the most trained. And so we went in. We had no option but really to start thinking on how do we diagnose TB, COVID. And we had a very well-developed sample referral system. We had a very well-developed gene expert network. And so all these were taken over for COVID in the initial times. So what we realized is soon the TB notification was reduced by 58% in that time. And also treatment went down, sample referral went down, issues of quality assurance for TB diagnosis were put on the side. And so we quickly see when we analyze that there were more errors, and issues of oversight, supervision were forgotten because the Ministry of Health headquarters, all we did is sit.
I think the conversation is such, right? Very intense. And so it's creating this experience, but maybe Moses will join us back as soon as he can reconnect. Maybe I'll shift the focus to you, Tamryn, to say, you know, you were the one, and Moses referred to this issue of stigma, and you were the one who broke the stigma by speaking about TB boldly on the stage. Now you're in the front lines treating patients. What is COVID triggering in you, and how do you look at the interplay between both? Just kind of share your story for all of us who are hearing you on the panel.
Yes. So my initial reaction to COVID, the first thing I was very concerned about is, they said all medical staff needs to report if they have any comorbidities. And so I have scarring on my lungs because of the TB I had previously. And at that point, there was not enough evidence or research done. And my question was, if I have to get COVID, will it be more severe because my lungs are already scarred, because it's both respiratory based? But eventually I got my answer, and they said, no, you won't be at a higher risk of contracting COVID or having it be more severe. So I felt more comfortable. That was my first reaction. Then what I started noticing is that there's some similarities with how people were treating COVID and how they were treating TB. But then there were also some very big differences within, speaking from a hospital perspective and as a doctor. What really surprised me with the differences is that, TB has been around for so long. We've been managing it, but for some reason in our public sectors, we struggle to find masks. We struggle to find PPE. And I mean, this has been going on for years when it comes to TB, you literally have to take your N95 home with you so that you can have it for the next day. When COVID came around, there was this rush, to everyone needs to get PPE. We need enough masks for everyone. And it was just surprising that why can't we have the same attitude towards managing TB, which has been there much longer. Something related to the stigma is, I had a patient that I dealt with personally who failed to disclose that she was diagnosed with COVID 2 days before. And she was coming in for a different problem to the hospital. So she was still COVID positive, but didn't want to disclose it. And it just showed me, well, when I spoke to her about it, it was the stigma, and again, it was a new disease. So even some of the staff, like the medical staff, were treating COVID patients differently. They were, kind of shunning them. No one wanted to interact with them, which again, we see is very similar to what was happening with TB. So that was very interesting for me to see. And as someone who's had TB, and I know the fear of what it can feel like, it helped me empathize and relate more with my patients. It helped me to step into a room with, my PPE and actually talk to these patients and find out what their concerns are. It was a very uncertain time, I think, but I think with COVID, it's just evolved so quickly, now it's up in your face. Everyone's talking about COVID. I think we're a little bit less shy now to say that we have COVID. And it's almost like TB has disappeared completely. No one's talking about it in the hospital. I don't even know where the TB patients are, because those wards and those rooms have been used for COVID patients. I'll be very honest. I'm in psychiatry now, so I'm not in internal medicine, but a lot of these TB patients are not showing up to hospital, first of all, because they're scared of COVID. They're scared of getting COVID. They're also scared that people are going to say they have COVID. And by the time that they get to us, the TB it's so severe that now we're dealing with them at a point of their illness where they need, they have multi-drug resistant TB, or it's just more extensive. So it's really sad. It's frightening to see what's happening when it comes to TB, and a lot of it is because of COVID. And it's not only TB, it's all the other chronic illnesses. No one wants to come to hospital either because they're scared of COVID. So we're going to face many waves of many chronic illnesses after COVID, including TB.
Yeah, you touched upon several important factors in your comments here. What happens to people who have scarred lungs from TB, and how does that play with COVID? So that interaction between a respiratory condition already and representing it with a new infection. You spoke about stigma. You spoke about the fact that TB is just, the conversation around TB was never this focused, even when there was no COVID. But COVID created this kind of rush for PPEs, masks, and stuff that should have been there for TB at all time. So you spoke about that. It's interesting, and I'm sure, you know, to look at something positive from this experience, I think people will then react to TB with the same sense of urgency. That's the hope, right? Because it spreads through air, it's airborne, and it's as fatal as, you know, as bad as, or worse, if you look at the numbers that Lucica was sharing. So I'm hoping that the sense of urgency will be there. But I want to ask you one question and then go back to Lucica. Have you been, you spoke about TB wards being used with COVID patients, which I can totally relate to just looking at what's happening here as well. But have the rapid tests in your country taken off the burden somewhat of decentralized testing? I think this is where Lucica was also talking, going to go with, you know, how has that kind of helped manage the burden? I don't think you can say there's no burden, but maybe the burden would have been twice as much if you didn't have these tests. And so is the rapid testing and PCR combination helping win this COVID crisis? I'm just interested in your thoughts.
No, it definitely is assisting. It's just helping us direct patients to, you know, where they need to be immediately, as soon as possible, to get the treatment as soon as possible. Whereas with the delayed test, it honestly, we had patients stacking up in wards. There were not enough beds. You can't really send them away because we're still waiting for results, but we also can't manage them accordingly. So the rapid test has really helped.
Yeah. So Lucica, if I were to ask you your comments on, you know, you've been looking at this space for so long. What lessons from COVID do you think should be applied for TB? Do you think that the TB pipeline is as robust? What excites you about potentially a technology that can further change the game in TB from the progress that has been made, so to say?
Yeah, so I have two, three points to make to this, and I hope Professor Moses will be able to join us, because you know, nothing can compare with someone speaking. I appreciate very much, Tamryn, what you said, because it's you and Professor Moses being there in the country, in the hospitals, and seeing what's happening in reality. But so two, three things to say. There are two aspects on the COVID. One is on the what we learned, and the other what we can do actually right now. So what I learned from it, if anything, I learned to be even more, I don't know, aggressive. I don't know if it's the right way, but even more unhappy with the status quo that for TB right now. And I learned as well that if you have a fear factor that scares people, unfortunately, people from the high income countries, the world gets mobilized, the world finds the money, and it is possible to find hundreds of diagnosis tools. You are able to develop a tool to diagnose a new disease in months. You are able to find the vaccine in 10 months. You are able to put billions in this. You are able to have live data, as I said. So all the things that for years, for hundreds of years, let's take that out, for tens of years, we are asking in TB, an airborne disease as COVID, similar in transmission, more contagious but less mortal than tuberculosis, obtained in less than a year. So it showed that it's possible. It showed that actually the money are available in almost every single country. Is not a money problem. And then if the money are not available, people get united together to help the others. Money are available to have now a pipeline of 210 vaccines for COVID in a pipeline. And in TB, just to make half of this room faint, in TB, we work with a BCG that is 100 years old. It helps just children in endemic countries. But to make you even more terrified, we worked for 14 years to arrive at a pipeline now that has 12 to 14 candidates. So we worked 14 years to arrive here. And we have a horizon of 5, 6 more years till we get a vaccine. I mean, for anyone that passed through last year, what I'm saying now is like, this woman is either crazy, either these people are complete idiots. There is no other explanation why, for an airborne disease that kills so many people, we are accepting this. So if I learn something from COVID, is that I'm not going to take the bullshit, sorry for my French, from the world leaders, from the governments. Oh my God, there are no money, $10,000 is a no. When you know what it implies, when you realize what it means, and when you are scared, you of course react. Now, TB is not as contagious, as I said, but TB kills more people in the African region now. Actually, TB kills more people than COVID in the Africa right now. So that's one thing that I learned. But the other one thing that I think we should learn, and it's a reality, is this, that the world realizes now that we have potential other pandemics that are airborne that will come. Any airborne pandemic that will come will have TB in it, because TB is airborne. Anything that we constructed for TB, it is helpful for COVID, as we saw, and it can be potential helpful for any other airborne disease. Are we smart enough to construct these platforms in which you can, for example, we speak about bidirectional screening and testing. So basically you say, okay, if I have a person coming to me, to my place, and I have a machine for rapid molecular diagnosis, a gene expert machine there, and I have the cartridges to do TB and COVID. Of course, I look over the symptoms and stuff like that, but I think that will be amazing that the person gets a COVID and the TB test. And in this way, you obviously catch more people and you are able to diagnose and so you can do that. You can also use, as I say, you asked me about what I'm excited as a tool. There are a lot of things now to bring the care closer to people. And you see, I am, for example, a promoter in Stop TB of this thing, which is said reimagining TB care. We launched that 3 years ago. We had some discussions. You were part of that, Tamryn, I think also, and you, Renuka, which means, we were used for a long time to go to a dispensary or a hospital to be diagnosed. Is it possible to bring the dispensary or the hospital closer to people? So now we have tools that are portable. The gene expert can be portable. You have X-ray that is portable. You can analyze the blood in very simple with a portable thing. You can do diabetes. You can check your eyes. So you can have a mini lab in a van, properly linked. Professor Moses doesn't need to travel with the van, but you have artificial intelligence now. Digital technology sends him the data. He sits in the office and can serve the entire Uganda, the entire Africa, if the network works. So putting digital technology, artificial intelligence, and securing access to people closer to their place, it's the future of what we have to do. And it is possible, and it is the way that we should think. The last point that I want to make is this, and maybe you don't give me the floor till the end. The civil society and communities are having a huge role to say. And very often we say, oh, involve civil society and communities, and people are like, okay, yes, and nobody unpacks, okay, like, what does it mean? So I think it means two things, and Professor Moses and Tamryn also spoke about that. On one hand, you need to have these networks at grassroots level of survivor communities available to really support people, to speak with them, to destigmatize, to tell them, guys, you can get vaccinated. There's no shame you get COVID and TB. There's no shame. Please discuss with the other members. So it's a part of communication and explaining and transmitting. And the other part is providing services and really being community health workers. Obviously, everybody properly equipped, properly trained, and paid, because very often people forget about that, but they will have a penetration in the population that is much bigger than what is expected, and they can be engaged for other future situations and other future pandemics. But anyway, so I will stop here. These are some of the things that can be done if we are smart, that can help us. Thank you.
You've touched again on many, many useful comments here, as always, Lucica. And the thing that sticks with me, and by the way, the chat comments are all kind of supporting what you've said. They're talking about, well, the commitment from the governments, the commitment from WHO on TB, in contrast to COVID. They want this message to be widely stated, just like how COVID's messages are communicated. So I think this is all great. And you spoke about reimagining TB care, taking the test to the patient. And you spoke about this mobile van and mobile clinic. And it's almost, in a way, going to the primary care settings to catch the missing millions proactively, if you may. You spoke about bidirectional testing. So all of these are great. I'd like to have a quick comment from Moses, who's back with us, and then Tamryn to say, are these decentralized testing models feasible? They seem to work with COVID in a manner because of the rapid tests, right? But how do you take, when you don't have those very rapid tests for TB, how do you take this like a lab in a van, as Lucica said? What are your experiences? So maybe Moses and then Tamryn to just quickly comment on that before we kind of go to the next round of questions.
I think, thank you very much. And I think what Dr. Lucica is trying to say, that we need to have access to testing close to the population. I know I am a big believer in Stop TB on the notion of same-day diagnosis, because if a patient comes and goes home without a result, that's already a problem. The amount of money, the delay you put in to do this is too much. And with the technology we have, if actually we are committed to TB, even a tenth of the money we have put in COVID, I think it would be a long way to achieve our targets. Because yes, to have mobile vans, have people tested the same day, get results, and be linked to care, I think that's the way to go. And I don't see, now technology is available, we could really do that, including decentralizing this test, and hopefully the Omni. We have been promised Omni for all these years. I wish they had put in all the investment necessary to have this test close to point of care as much as possible. I would say that for now.
Yeah, and it's interesting, Moses, when we were chatting earlier, you were also talking about somehow the mindset of people, right? They forget, Lucica spoke about the fear factor. If there's fear, then there's action and the sense of urgency, and somehow resources get mobilized. And when you kind of take things that it's not as, deadly, or it's not, you become complacent. And that we were speaking in the context of vaccines, right? With vaccines being rolled out for COVID, do you think there's a sense of complacency for people to kind of continue testing and continue doing that? Maybe we'll hear from Tamryn, and then I want you to answer that question. So Tamryn, first on this decentralized point of care, do you think that can work in a country like South Africa, where you have many, many hotspots of multiple comorbidities, right? So let me hear your view.
I definitely think it will help us very much. And it's like Lucica said, that the infrastructure, and Prof said, it's available now. We're putting all these things in place for COVID, and because they're both airborne, they're both respiratory illnesses, you can use the same infrastructure for TB, which makes it quite hopeful. And I'm hoping that they're going to focus it on that. Like even in the hospitals, you can see, the infrastructure was put in place for COVID. There's whole new wards that have been created with ventilation, with masks available at every point, with sanitizing, and it's all for COVID, but the exact same things can be used to manage TB. So I definitely think it will make a very big difference, and it can be decentralized in South Africa.
Yeah. So Moses, what do you think about vaccination and then the need for testing? Do you think we need to continue not to lose sight on COVID testing? Of course, TB testing, and we'll come back to the bidirectional testing that Lucica spoke about. But what do you think about what's going on in vaccination in both your countries, Uganda and then in South Africa, Tamryn? So a quick comment on rolling out vaccination, but continuing to keep the eye or the ball on testing going forward.
Well, I think I do believe in vaccines, that the vaccines are very good things and they will help in this pandemic. But going by what we see, for example, in Uganda, So far, we have vaccinated 0.62% of the population. And while there is a challenge of getting access to the vaccine, but on the other hand, there is a challenge of hesitancy on people accepting to take the vaccine. So I really don't see this as a solution in the immediate future. And of course, you would predict, even if you really did vaccinate, this disease has already spread, we will continue having a few sporadic cases here and there in the longer term. So there is no shortcut for us to develop capacity for diagnosis and getting the diagnosis right and in time for people. So I think that's what I would really want to say about the vaccine. But it's a good thing, but for us in Africa, it is still a long shot, I would say.
Tamryn, your reactions on the vaccination scene in South Africa and the need to keep the testing focus, as Moses was saying, what are your views? Is it different in South Africa, or do you?
I think it's very similar to what Moses said. I don't know if I can say it any better. It's very difficult for me to speak from a perspective of, what Moses and Lucica are speaking from, because I don't really sit with statistics and I don't really know the numbers. I'm more someone who speaks from just being a doctor and what I'm seeing in front of me. But there's definitely still a lot of hesitancy around taking the vaccination. It's again, myths and the stigma. There's stigma and myths around the vaccinations as well. And it's very prevalent in South Africa, even amongst our healthcare workers. So we can't completely trust that the vaccination is what's going to, save us and make things better. We have to continue with our testing and coming up with other strategies of, fighting this fight and overcoming it.
And do you have any evidence or experiences that you've been seeing in your observations, both Moses and Tamryn, on actually how testing may be shining the light on hotspots, maybe directing where vaccination efforts should happen? Is it the thought process, or is that kind of far out still in your thinking?
I don't know, Prof can start.
Sure, the testing is really capable of showing where the hotspot is. And the COVID, it is an acute disease. It's not a complex, according to me, I'm not a tough epidemiologist, but where there is COVID, you will quickly soon notice. And of course, you definitely want to go with testing, and testing pays. The more you test, the more you have the control and know how your efforts are working. But remember, this test is very expensive as of now in terms of for government and also for individuals. It's a very expensive one. So, however, it is the best tool I think we do have, because the earlier you know, the better you handle this in terms of epidemiological control and management. That's what I would want to say.
So from what I've sorry Renuka, from what I've observed in South Africa, or just where I am, the tests are not very specific to certain regions. It doesn't really show or highlight us where the what's the word that you used, like the hotspots are. In our case, we're focusing on vaccinating people according to healthcare workers first, because they're more at risk and it's who we need on the front lines at the moment. So essential workers, then it's those with comorbidities and age. We're not really running the vaccinations in a sense of, here's a hotspot, okay, we need to focus it there and send all our vaccinations there at the moment. So that is something that I've noticed on our end.
Yeah, so there's still ways you could use diagnostics and testings to guide, where your action should be stronger or strengthened. So that's something I hope governments will take on. There's a question here, Lucica might be able to address this, to say, do you have any great examples or best practice where you're seeing both COVID and TB being catered to in a, let me read the specific, are there good examples of where TB and COVID services have been offered together so that the delivery of TB services is resumed, especially in the context of ACF and contact tracing? So
yes.
So would you want to talk about that, Lucica?
Yes, and it's actually in a way breaking my heart because the example is from India. You see, what you need to put these things in places is to know what's happening in your field and to act quickly, right? The moment you see there is a drop, you need to act quickly. So last year, India observed that after Q2, there was a 40%, I know professor here said about, as well, other countries in which there were significant drops in the months of lockdowns and so on. So when Indian authorities saw that there was this big dramatic drop, big and dramatic drop in the case notification, they said, we need to do something about it. And they put it in a sort of action plan in place, not for the blah, 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 but very concrete. And that was implying door to door of people. That's why I say communities, health workers going around for people to see if they have symptoms, to encourage them to go to the diagnosis, to speak with them, to encourage those that were on treatment as treatment supporters to provide whatever was needed. But also the bidirectional testing was actually happening. And in such a way that by the end of the year, you saw this with India, you saw a V, right? It dropped and then it went back. Following their example, or not necessarily following their example, Indonesia started doing that and offering bidirectional testing, as well as some of the European countries. And I think the plan is to do the same, or was to do the same, exactly the same in South Africa. And I think in, if I'm not wrong, Kenya as well. The point is the scale you do that, you know what I mean? And the perseverance that you have to do that. And, we all know that routine is killing us. And we all know that, for doing that, because even contact tracing was happening, right? You need resources and you need the people to be properly remunerated, to be properly equipped to continue, and not tired and not fed up. And in our rush to address COVID, we forget about all these things. It's also, it's very easy to say this, it worked in India, right? And they kept the pressure. The other thing was that the political commitment was there. So actually every single month, the Prime Minister and the Minister were discussing about what's happening with TB in the country during the COVID, which is very unique. Yeah. Now, the last point that I want to make is to be able to do that, you need to have the right tools in the right place. And if you speak just simple, as I said, diagnosis, it's very easy to see do bidirectional. But if the gene expert machine, let's say, are just the big ones, and they are just located in the big capital city or in other few big hospitals, you need to either have a system to bring the people there, or you need to transport the sputum. And so be honest, the sputum transportation systems can be a hell of a job. And I think people are sometimes dreaming about them. I am of the opinion that you better deploy the tools closer to people rather than run with the car around, because I used to be in charge with the sputum transportation system in my country, which was Romania, and was a hell. Our roads are bad. The drivers sometimes were getting drunk and forgetting to leaving the car in the sun. We all know what the sun can do with the recipients of sputum on the chair in the back, sun on all of it. It was a disaster. So it created more headaches, the sputum transportation system, than put a smaller diagnosis unit in a more peripheral place and so on, which is what we said. So the examples, I can enter into more details. If anyone is interested, we can do something and share with the concrete people that we are doing in India, in Indonesia, and even Philippines, sorry. Again, the ones that did that scale was India. The other ones are fewer. But with the COVID-19 RM Global Fund money, we are trying to push for the same thinking of bidirectional screening and testing as part of this mitigation of impact of COVID on HIV, TB, and malaria. And we hope that this will happen. So we will be able to share at least, or not, I didn't do any of this. So we put in contact the people that did the real work, that then questions can be asked and say, so we can think of a follow-up in a concrete way.
I actually like this conversation very much, Lucica, because I think we need to bring real concrete examples and best practices that one can learn from each other. I mean, sadly, the situation in India today doesn't lend itself to become the best practice example, just because how COVID came back in this second wave. The intention to address TB was great and the action was great, but this unexpected surge and the rate and pace is just distorted. But I like what you're saying in terms of global funds proposals. And I think this is very important for all country leaders who are on this call to kind of take back to their country governments, because now you have new funding, COVID-19 funding, and you have an agency that's looking at not just COVID, no more just silos, but they're looking at COVID, HIV, TB, all of them are comorbidities. And if there are proposals coming in from the country that can address both bidirectional testing, that would be very welcomed, I believe, from a global fund perspective, because it addresses the dual monsters, if you will. And then that, Lucica, maybe, I'm sure I'm speaking on behalf of our colleagues at ASLM, but they would love to come back with, here's a best practice case that you have looked at from how both COVID and TB can be met. It could be a great learning experience. It also puts to me one final question, and I'd want to kind of make it rapid for each one. You know, policies make such a big difference in countries. Do you think, Lucica, a bidirectional testing policy can come up from, I don't know whether that's WHO, usually policies are a long drawn process, but how do you create that sense of, you know, if you have a policy, then governments react to it and this message about bidirectional testing goes. So what's your thought? And then I'm going to move to Moses and Tamryn to say, what would be your call to action? Just keep thinking of that question as Lucica starts to answer this policy question.
Sorry, I was muted. In my building here, everybody is constructing. Since I work home, is like everybody is redesigning their apartments. It's like continuous drilling here. I don't know what they do, but I want to say that I put in the chat the link to 2 documents that are speaking specifically about the simultaneous testing or and as well contact tracing. So I put the link in the chat. Then I will disconnect after I answer this, not because I'm unpolite, but because I have to join a call at 4, that it's my board. So, you know, when you have call with the boards, you need to behave. And I want to say, I think it will be important. So our colleagues from WHO fully understand and appreciate this. And I think they will, they are fully on board. You know, it takes time for WHO to issue guidance, as you know, and now they are firefighting a lot of other issues. But I think recommendation on an approach of bidirectional screening and then testing, you know, you look first of like if you have a line of people for COVID like we do now, you don't go to everyone, but you look at symptoms. I mean, you know, there is a little algorithm even in this document there that not for every single one, but obviously the uptake is rather big. And if you create the platform in the field if you create the platform available that you can do that for TB and COVID, you can then apply it for anything else, especially for the tools and machines that can multiplex. So, you know, I think we might be able to do it even before, you know, like sometimes countries follow WHO, but sometimes countries, because of the need, they need to do something. So it might be actually a collective push from bottom up and push WHO to take this kind of decisions or come concomitantly. I think the governments will have to start thinking in this way, that places in which you can do diagnosis for multiple primary healthcare, health units, community health workers, it's the future for that. So that can be something that I actually think is possible to happen.
Thank you so much, Lucica. And I know you have to go to your board call, so I really appreciate your comments, and I'll be wrapping up the session with comments from your end or the summary based on your comments as well, and with the promise to be back in touch to do more of these. But let me move to Moses and Tamryn for your final words and comments. What's your call to action? What would you want? What's your one thing that could just change the curve, so to say?
Well, of course, to me, there are of course, if I had my way, I think from the TB angle, I would say this is COVID is a wake-up call. Let's put the resources there. Because if we had, like I've said before, put a little bit of the resources we have put in COVID, we would be in a better position. The technology exists, the ability to control and eliminate TB is there. It's just the resources we need to have that out of the way, and then we focus our effort on other things. But for COVID, I think we should not relax. We should really, provide good guidance, like you have had good practice elsewhere, this bidirectional testing, also get the vaccines in there, and I think we get the vaccines accessible to us and provide resources for testing to guide the response. I would say that for now.
Thank you, Moses. And Tamryn, over to you. I think, Tamryn, you're on mute.
There we go. Sorry about that. Yeah. I think coming from someone who's a survivor and of TB, who's also a survivor of COVID, I had both, and who's a doctor working on the ground level, I think my call to action for me is something that's going to be more direct to the people that I see, that all of us health professionals see. And I think it's to all survivors, whether it's TB or COVID, share your story, talk about it openly and educate the people around you. Share your story and break the stigma, because we are facing stigma with TB, with COVID, and with our vaccines. And it's really preventing all three areas from, really reaching the potential that it can because of all the stigma. So it's something simple. I don't know how big of an impact it will make, but I think that is something that's dear to my heart.
Yeah, and I want to say, Tamryn, you've always been sharing your story and you lead by example. And I think the idea of breaking the stigma by saying it's okay to get TB, okay to get COVID, but here's what you need to do to act is an important takeaway. And I think, I hope we can create that movement. It's a bit like grassroots civil society engagement.
It's what I want to see in our communities, I know there's high-level meetings and high-level strategies that are taking place, but I think from a community perspective, that is something that can be really encouraged.
Right. So I think I really find all of these discussions fantastic. I just want to kind of wrap up with some thoughts and of what I heard as a summary to say, TB really needs the attention that COVID's getting. There is an opportunity with the interconnectedness of the world to say how perhaps COVID will bring greater resources to TB, and it should be each one of our jobs to continue to advocate for that. There are many lessons learned from how we addressed COVID in a dramatically quicker way, and that can be passed on to the TB world. This bidirectional testing is an opportunity where funding is being provided by a global fund, and if governments can incorporate that into their national plan, irrespective of the bidirectional testing, there's a real reason, a need to continue sharing stories, continuing the advocacy, to taking tests and solutions to the patients wherever feasible, to kind of catch the missing millions and to get care and treatment rapidly is what I heard as well. And to continue sharing best practices. We have some resources that Lucica shared with everyone, and we'll come back with a story where we have a good community level engagement, a good bidirectional testing, and hopefully a success. But meanwhile, both TB and COVID are respiratory conditions, both are lethal, both are can be avoided. You can win that battle if we collectively act together. Really thank ASLM for pulling this session. Again, very, very informative, very conversational style. I really want to thank Professor Moses Joloba, Dr. Tamryn Green, and Lucica for this valuable comments. And over to you, Anafi, for closing this out.
Thank you, Renuka. Thank you, Prof. Moses. Thank you, Dr. Tamryn, and in absentia, Dr. Lucica, for the wonderful discussion. And to borrow the words that Tamryn used, she said, share your story and break the stigma. And I'm proud to say, in a way, this is what we do at the LabCorp. We call upon country teams to share their stories. And it's not only about stigma, but it's sharing their best practices, sharing what they are doing. And as evidenced by what we have learned today, I think this is what is happening. And of late, we have really started talking more around diagnostic integration of services. How can we take care of COVID-19 on a routine basis into HIV and TB diagnostics? And we will be reaching out to you individually as the countries to see how we can be able to work together to achieve this. Ladies and gentlemen, on your screen right now, I'm going to be displaying the code for, as usual, the certificate. If you want to download your certificate of attendance for having been here for the past 1 hour, just to borrow again the words from Renuka at the beginning, she said, you don't know how long a minute can be, but once it is just stated, you wonder how short an hour can be. Till we meet again, thank you and goodbye.
Thank you all.
Thank you.
Thank you.